Dr. Somsdar, we can start. Is that okay?
Just 1 minute. I'll share the slides, the
No,
CV
we can do that
slides.
after. First, we'll give the intro and then pediatrician's prayer, and then we can.
Yeah.
சாரோட இதெல்லாம் paste.
Yeah.
Just
நீங்க
start
intro
பண்ணுங்க.
கொடுத்துருங்க. You can start the intro. I'll then
Okay, good
introduce
evening,
this.
everyone. It gives me great pleasure to be here on this Sunday evening for another edition of our pediatric PDNE program. This is the sixth in the series actually for this month. I will request Dr. Rajkumar, our treasurer, to say start the program with the pediatrician's prayer.
Thank you, Thiru. Pediatrician prayer. Grant us the quality of holistic healing. May we humbly realize how privileged we are in being bestowed with the ability to alleviate suffering. May we be emissaries of health, learning, charity, love, peace to all children and their families, irrespective of status and creed. Give us the wisdom, understanding to change the things we can, retain the good, and accept within reason the things we cannot change. Grant us our blessings, grace, and mercy in all situations, at all times, amid all people. Thank you. Over to you, Thiru.
Thank you very much, Dr. Rajkumar. Now I request our scientific advisor, Dr. Singaravalu sir, to address the people here. So you're muted, sir.
Unmute, sir.
Sir, you are muted, sir.
Singaravalu sir, you are muted.
Am I audible, sir?
Yes, yeah.
Now better.
Good evening to all. I'm extremely very happy to welcome you all for our monthly meeting, the expert session, which is going on very well for the past 9 months. And it was a wonderful event for the benefit of our practitioners and our postgraduates and also practicing pediatricians. In this series today, we took pediatric cardiology, and the person who is doing extremely well, where I could witness in his hospital, one of the biggest hospital in Thane, Mumbai, where Dr. Srinivasan and his team is doing extremely well. I was overwhelmed by his way of work and the respect he is gaining there. So I thought he should be today's program. He readily accepted for that. First time welcome our guest speaker, supported by Madam also in his team. And our academic coordinator always, whatever program we does, it will be done immediately. And our coordinator for this program, our president of Chennai City branch and our state president-elect, none other than our developmental pediatrician, Dr. Somsundaram sir, and our dynamic secretary, Narmada in absentia, and treasurer Rajkumar. And today program is joined by many solvers, always our Professor Srinivasan sir, our Devendra Sarin has joined, our very eminent young budding pediatric gastroenterologist, Dr. MSV has joined, and many others have joined. Here we got a lot of academic activities where I have been given the opportunity to serve as a scientific advisor. So wherever I go for campaigning, everything is uploaded in the YouTube, that our academic coordinators see that whatever program is being done, it is properly recorded, because it goes in YouTube. Immediately it will be, people will see in the live, and it will be in the website also. So that gives extensive credential to our academic program about our Tamil Nadu IAP. Always Tamil Nadu is a forerunner of academic, but this year is a unique, that lot of activities which is being properly recorded and put in websites. So many of them are getting viewed and they are benefited. So with this, as a scientific advisor for giving me this opportunity to introduce my good friend Dr. Srinivasan and his team from Kim's Hospital, one of the very, very big multi-specialty hospital where he is, started his career and he is doing extremely well. And over to our person, Dr. Somsundaram sir, to take over the proceedings of today's program. Over to you, sir.
Yeah. So thank you, Dr. Thiru, the academic coordinator, and our scientific convener, Dr. Singaravelu sir. So thank you for giving giving us two speakers at the national level. So I'd like to introduce both the speakers.
Before introducing, just one word. Dr. Somsundaram, just only one word. I would like to welcome Dr. Ramakrishna Paramahamsa sir, and also to say that Dr. Rajendran is having severe connectivity issues, so he will join very shortly. He's just driving back from his native place. So sorry about it. So sorry. Thank you.
Welcome,
Over to Dr.
welcome Ramakrishna Paramahamsa sir. Welcome, sir.
Welcome,
Yeah.
sir.
So Dr. L. Srinivas is it's an interventional pediatric cardiologist with his DNB Pediatrics, FNB Pediatric Cardiology. The fellow is fellow cardiology from Sydney, Australia, and FPICS from USA, with more than 16 years of experience in pediatric cardiology, and has performed over 5,000 successful catheter interventions, showcasing his enhanced expertise in the field. So he has got various awards to his credit, various research and publications, and his areas of expertise are catheter interventions, device closures, advanced imaging, including transesophageal echoes, cardiac CT, MRI, pediatric cardiac intensive care, clinical cardiology, fetal echocardiography, and lot more to add on Dr. Srinivas. So he will be covering on approach to acyanotic heart disease and timing of intervention. I will also introduce at the same time our co-faculty of Dr. Sonia. Yeah. So Madam is a junior consultant, pediatric and fetal cardiologist from Jupiter Hospital, Thane, Maharashtra, with a DNB Pediatrics, MRCPH, FCPC Pediatric Cardiology, and fellow fetal cardiology from AIMS Kochi. A special interest are fetal cardiology, including fetal echo and 3D imaging, fetal 3D printing for planned immediate neonatal surgeries, and fetal cardiac intervention. She has got various publications in various reputed journals, and she is also the co-faculty in Amrita Fetal Heart Learning Module 2025. And she will be covering on the fetal diagnosis of congenital heart disease and the impact on treatment outcomes. So with this initial introduction, let me call upon Dr. Srinivas, and we have our president, Professor Dr. K. Rajendran. Sir, over to you to have a few words. We have just introduced the speakers.
Thank you, Dr. Somsundaram, and sorry for the apology for the late joining. And most respected our scientific advisor, Dr. Singaravelu sir, and all other senior IAP Tamil Nadu Abispara's as well as centrally as well as state EB members, and our President-elect Dr. Somasundaram, and academic coordinator Dr. Tirumurugan, Rajkumar, and Dr. Narmada. And it's a great pleasure and privilege to be here. And I really welcome our national experts, Dr. Srinivas, and as well as Dr. Sonia from Thane. And it definitely will be useful for our basics to recent advances they're going to talk about today's class. And thank you very much for this wonderful opportunity. Thank you.
Yeah. So, sir, Dr.
Sir,
Srinivas.
Sir, Sudam could have joined Maniskar, sir. Yes, Sudam has joined.
Hello?
Sudam joined Maniskar, sir.
Yeah.
Sudam Mangal is it?
Sudam Mangal.
Yes, sir. Good evening. Good evening.
Yeah, you can have a few words, Dr. Sudam Mangal, please. He's one of our postgraduate, and he's really excellent person, and you done DNB at KMCH Hospital, Coimbatore, and he's one of the best outgoing, I can say. And I really welcome Dr. Sudham, please. Yeah, a few words you can talk.
It's always pleasure to listen Tamil Nadu IIT online conference. I have attended many so far. And today, I think Dr. Srinivasan sir and Dr. Sonia both, we three are working in the same hospital. It's pleasure to listen Srinivasan sir always. So thank you.
Okay. Yeah, please,
Yeah.
sir, sir, please.
So, Dr. Srinivas sir, you can start sharing.
Sure, sir. So just before sharing, I would like to welcome Dr. Sunil GS. Sir has also joined for the meeting. Dr. Sunil GS is a pediatric cardiac surgeon working with us in KIMS Hospital. So he has served almost more than 20 years in congenital heart surgery, Amrita, then Aster, and Tirupati. Sir has a huge experience and an excellent hands. So 100% dedicated to his specialty. It's our fortune that sir has joined for this meeting. Welcome, sir.
Welcome, Dr. Sunil sir, on behalf of IAP TNSC.
Sir, I'm sharing my slides.
Yeah.
Okay. I hope you can see the slides, sir.
Yeah, sir. It's visible, sir.
Yeah, thank you. Good evening, esteemed faculty, especially so many senior faculty from Tamil Nadu, IAP, Srinivasan sir, especially teacher of teachers, and all the other dignitaries who have joined for today's meeting, and also students and other teachers who are all on YouTube. Welcome. So today's topic is approach to acyanotic congenital heart disease and timing of intervention. I would want to simplify this topic as much as possible. So I might actually use a little unorthodox method of going through this topic. You must have heard of this topic time and again. So let's see if we can actually make a difference with today's talk. Okay. So to begin with, so if I show this slide, presentation of dangerous heart diseases through the timeline, as a pediatrician, we will be happy because 90% of the dangerous heart diseases all present during the early infancy or in the neonatal period. If we say all the TGAs, if this is a timeline from zero to infancy, all TGAs, intact septum, obstructed TAPVCs, critical aortic stenosis, critical PS, all of them do present very, very early. Most of them on day 0 or within first 2 weeks of life. Duct-dependent circulations like HLHS, severe coarctation, pulmonary atresia, and those complexes present with the time of duct closure. And then the third group, which are very unusual left to right shunts, which are associated with high mortality, which are associated with coarctation, truncus, all present within first 2 weeks of life. So that means neonatologists are the one which are dealing with such life-threatening critical congenital heart disease. Tetralogists typically present during the later half of the infancy, a straightforward tetralogy. Of course, tetralogy with severe PS can present early enough like a duct-dependent circulation. So this is what happens. While arrhythmia does not follow any rules, arrhythmias can present throughout the life. So once we have this slide, what we are dealing today is acyanotic congenital heart disease. So usually they present little later in life, after 4 to 6 weeks of life. So they won't be seen as an emergency to us. So this is a typical textbook flow chart that we have seen in many, many textbooks. A lot of terminology, a lot of jargons, a lot of confusion with this. A student might actually mug up and reproduce this in a textbook, but once we come into the practice, this does not make much sense because with time, because most of the pediatricians are not seeing these diseases regularly, so it is rather confusing. So this is the reason that I don't want to go through a flow chart like this. Today we'll go through a different physiological approach. For time constraints, we'll restrict ourselves only to the acyanotic congenital heart disease today. So the reason I was saying is a child does not come with a table like this, or you will not take out the table every time you suspect a heart disease in the child. So let us attempt to address the child based on the symptoms or physiological approach. So let's suppose just symptoms of presentation. So you have basically 4 symptoms of heart disease presentation in child. You have cyanosis, you have congestive heart failure, you have symptoms of obstruction, and you have arrhythmias. So what do? We treat only the symptom as a clinician, as a pediatrician, even as a pediatric cardiologist in the initial phase. If there is a cyanosis, we would try to increase the pulmonary blood flow or optimize the pulmonary blood flow by various methods. If the patient has congestive heart failure, we treat them with diuretics, we treat them with digoxin, we treat them with enalapril. We do not mix up the two. The minute we see tetralogy, we do not give anti-failure medications. Same thing, the minute you see cyanosis, you're not going to do the other way. So these two are typically symptom-based approach. Then you have obstruction. Majority of the obstructions are asymptomatic. Luckily, you just hear a loud murmur and arrhythmias. Of course, we have to control the arrhythmias. So this simplifies the whole cardiology approach in a way that you see the child. Okay, to have a physiological approach, you need this basic set of data. What is this? A good history, a reasonable auscultation, without going into very intricate details of systolic, diastolic sounds, murmurs, grades, and all those things, just a routine auscultation. Use of pulse oximetry, which is more or less mandatory in every child with congenital heart disease, and measurement of blood pressure age appropriate. Any child who's more than 3 years should have at least one blood pressure measure. Any child who is more than 6 years should have a blood pressure measurement at every clinic visit. So this is a recommendation for blood pressure management. So if the suspicion of heart disease is more stronger, I would further recommend that you get an ECG and X-ray as well, so that we do not miss any child who is suspected of a heart disease. So in a routine OPD practice, even if we stick to these 4 clinical parameters, that is history, examination, pulse oximetry, and blood pressure measurement, we will not miss 95% of the congenital heart diseases. And using this data, we can actually diagnose them. How? Very simple. So the first group of patients have significant cyanosis. They come with cyanosis. Again, please use pulse oximeter, because in a busy clinic, we might miss cyanosis in these children. And these children typically do not have any history of congestive heart failure. They have a quiet precordium. That means the precordium is not active. They might have a murmur. So all of them fit into tetralogy physiology. Second group of patients, they may have mild cyanosis. Again, we might miss this 85 to 95% use pulse oximeter, but they have history of congestive heart failure. So these children will fall into admixture physiology. Okay. So these two, anyway, we are not going to deal with it today. So for today's purpose, we are going to deal with acyanotic heart disease. That means you have applied pulse oximeter. Patient has a saturation of 95%. They might have signs of heart failure, that is CHF, cardiomegaly, and hyperactive precordium. All of them would invariably have significant left to right shunts. So this is the most common and major group of diseases that we are going to see. There's one more group where you don't have cyanosis, you don't have heart failure, you don't have cardiomegaly, but you have a prominent murmur, loud murmur, except everything else. So these are typically your small left to right shunts, like VSD, small VSDs, a large ASD, or valvular heart disease, ASPS, or mitral regurgitation. Last group is often very, very misleading, because they all present with respiratory distress. They can present with no cyanosis, but with cardiomegaly, but no murmur. So all of them could have cardiomyopathies. Okay, with this very, very simplified approach, you can actually categorize the patients who are coming to your OPD into one of these baskets. Of course, there are some exceptions to this rule, but as I said, 95% of our patients, if you follow this 1 to 5 approaches, you can classify into one of them. Again, as I said, this is an unorthodox approach, but for a clinician, it is very good, because the amount of data that we need to classify them is very minimal, and it can be quickly done in your busy practices. So for today's discussion purpose, we are going to stick to only acyanotic congenital heart disease. So once we say acyanotic congenital heart disease, again, there are 3 broad categories. One is left to right shunts. In this, the most common is ASD, VSD, PD, AP window, etc. Obstructive lesions, which is aortic stenosis, pulmonary stenosis, coarctation of aorta, and we have some miscellaneous. Again, for today's discussion, we'll stick to 1 and 2 type of category. Okay. So is it possible to diagnose these patients based on only clinical signs without an echocardiography? Can a pediatrician pick up all these things and differentiate between all these things? Remember, these 3 category of patients will have a murmur, will not have cyanosis, may or may not have a symptom. Okay, let's see what we can do about it. Okay, if you see signs and symptoms of heart failure, only the category number 1 and category number 3 will have history of heart failure with signs of heart failure as well. Whereas patients with aortic stenosis, pulmonary stenosis, remember, coarctation of aorta, do not have any symptom at all. That means a child can go undetected with a coarctation for several years. That's the reason why I said blood pressure measurement is very, very important for every clinic visit. Okay. So if we come to active precordium, that means you just unbutton the patient's chest and see how the precordium is. If it is very active, that is active precordium. So you can have active precordium in category and category 2, 3. Again, this shows the signs of volume overload of the heart, whereas in category 2, it may not be there. If it comes to murmur, Category 1, 2 has loud murmur. Category 3 does not have much murmur because they're all like cardiomyopathy. Okay, they don't produce much murmur. Sometimes you might get a TR murmur, but usually
Yes.
no. Okay, so if you do an X-ray, cardiomegaly can be seen in category 1 and category 3. Again, no cardiomegaly in category 2. So essentially, your category 2 patients will present only with murmur and nothing else. Category 1 and 3 will usually present with signs and symptoms of heart failure. Category 3 does not have a murmur. So it is another way of differentiating between these three. If you just have a murmur, see what is there. Remember this table or go to the symptom-wise approach that I showed in the previous table. So it is possible to narrow down on your further diagnosis before sending this patient for an echo. So if we come to left to right shunts, ASD, VSD, PD are the most common left to right shunts. Okay. So what are the effects of left to right shunts? There is volume overload. That means there is more blood volume in the lungs than in the systemic circulation. There is pressure overload. That means the pulmonary hypertension is present. Okay. So volume overload signs are left or right heart dilatation that can be seen as cardiomegaly based on clinical examination or on the chest X-ray. There will be signs of increased pulmonary blood flow. There is congestive heart failure. Okay. Pressure overload means hyperkinetic pulmonary hypertension. These patients will have pulmonary hypertension. Okay. So just a small jargon about what we normally use, the nomenclature. We always use QPQS. I think most of you will know what is QPQS. QP is the pulmonary blood flow. There is amount of blood that is circulating in the pulmonary circulation. QS is systemic blood flow. That means amount of blood circulating QS. In a normal patient, in a normal healthy individual, QP will be equal to QS because same amount of blood will circulate through pulmonary and systemic because it's a continuous circuit. Okay. Whereas in a patient with a left to right shunt, their pulmonary blood flow is typically increased. That means QP is more than QS. It could be 2:1, 3:1, 4:1, etc. In cyanotic heart disease patient, QPQS is less. That means less amount of blood flow is there in the lung. That means 0.5, 0.8:1, etc. If we say there is increased pulmonary vascular resistance, that means resistance is increased. And if we say that pulmonary hypertension is present, there will be two types of pulmonary hypertension. If you have increased QP and pulmonary hypertension, it is called as hyperkinetic. These children are typically operable. They are not inoperable. Second variety is the one which is Eisenmeinger's, which has high resistance and low QP. That means there is right to left shunt or shunt reversal. So this variety of patients are called as Eisenmeinger's. The reason I'm stressing on this point is that when you get an echo report from a cardiologist, if the cardiologist writes just severe pulmonary hypertension, it does not mean that the patient has Eisenmeinger's, okay? And you should not treat them with sildenafil. Because if you give sildenafil for this category of patient where there is hyperkinetic pulmonary hypertension, patient would further worsen. So you have to see if there is increased pulmonary blood flow. If there is increased pulmonary blood flow, do not give sildenafil. Treatment is diuretics and send for surgery. Okay, so this is the same one, repetition again. So this is what we have, two varieties. One is hyperkinetic, second is Eisenmeinger's. These are the signs that you can pick up and differentiate between both. Okay, high pressure always does not mean Eisenmeinger's. Okay, so we always have seen pre-tricuspid shunt and post-tricuspid shunts. So why we use this terminology is because ASD is a typical pre-tricuspid shunt. Here, there is no pulmonary hypertension. There is only left to right shunt. There is only RA-RV enlargement. Whereas VSD or PDA is a post-tricuspid shunt. Here you both have pulmonary hypertension as well as increased pulmonary blood flow. Okay, so by now you must be knowing that all patients with a large VSD and a large PDA will invariably have severe pulmonary hypertension. Always remember this. Okay, so with this, let us go to this variety of atrial septal defects. So standard textbook picture and classification of ASD, 4 different types of ASD. Most common is ostium secundum ASD, ostium primum, which happens in patients with Down syndrome and very rarely without Downs also. There is also sinus venosus defect, which happens here close to the SVCRA junction, and coronary sinus TAPVC, which is unroofed coronary sinus. Okay, so here. Okay, these are the 4 varieties. How do you diagnose ASD clinically? Majority of the patients who come to pediatrician are asymptomatic. They are incidentally detected during a routine examination. More so if the child is admitted, you are auscultating for a respiratory sound, you might hear a murmur. Okay, so apart from that, S1, S2 could be heard. S2 is typically wide and fixed split. Ejection systolic murmur is there. MDM may or may not be there. JVP is normal because these children are asymptomatic. X-ray, if it is done for any reason, it will show increased pulmonary blood flow and dilated pulmonary arteries. Echocardiogram, of course, is diagnostic. Okay, so 99% of the children with ASD will just need only a transthoracic echo. They don't need a transesophageal echo. Transesophageal echo may be rarely required in an older child or when we plan an intervention. Okay, the most common modality is a routine transthoracic echocardiography. What is the common age of presentation? ASD is a disease that can present from any age, from infancy till geriatric. Okay, so when to close an ASD? So below 3 years, it is extremely rare that we close an ASD because they are all asymptomatic. It does not interfere with any of the child's growth parameters or developmental parameters. Most common age to close is after 3 to 5 years of age, whenever they present. Okay, so because they may or may not have symptoms, but all of them will have RARV dilatation. And these are the children who would actually might become predisposed to Eisenmenger syndrome or develop respiratory infections while they after they join the school. ASD in elderly, again, it's a very controversial topic. So, and it's not relevant to today's meeting. So I'm not going to discuss that. Does every child who has an ASD diagnosed an echocardiogram need closure? Okay, actually no. Small ASD without evidence of right ventricular enlargement, without any symptoms, there is no need to close every single ASD. Again, PFO, whatever the size of PFO, is extremely common in infancy. Normally, in our hospital, if we diagnose PFO, we counsel parents that the child has a normal echo. There is no need to repeat an echo to see if it has closed or not. So, such small ASD should not be followed up, okay, because they are harmless. If it is large ASD, as it is defined by volume overload of the heart, okay, so if there are symptoms, we close it at any age. If they are asymptomatic, wait till certain age, 3 to 5 years, and then either do a device closure or surgical closure. Bottom line, you must have seen sinus venosus SD, ostium primum SD, mallined SDs, all of them are usually large and all of them would require surgical closure. These are not suitable for device closure. Okay, so caution and contraindications, as I said, small ASDs, no need to close. ASD with pulmonary hypertension. Again, this is a discretion of a cardiologist. If we see pulmonary hypertension in a patient with ASD, we do not close it. ASD with mitral or tricuspidal pathology, we always have to repair mitral and tricuspidal pathology at the time of closure. Just closing ASD with a device is not enough. ASD with arrhythmia, some of the children, especially in the second decade, they might have associated arrhythmia because of right atrial enlargement. So the arrhythmia needs to be tackled first and then ASD has to be closed. How young in ASD can we close? As I said, less than 3 years. Usually they are asymptomatic, so we follow them up and conservative management. 5% of these patients below 3 years might require closure. And again, by default, majority of these children would require surgery. Very small percentage of these patients are suitable for device closure. It's extremely rare for us to put a device in a patient who is less than 3 years old. It is not safe also. So how does one close ASD? Surgery or device? Yes, you do an echo, see whether the device defect is suitable for device or surgery. Okay, so of course, every patient is suitable for surgery. So around 30% of the patients would be suitable for device. So we close them with a device closure. What form of echo is required? Again, this is a typical example of a transthoracic echocardiogram. Here you can see, so this is the atrial septal defect. Okay, so there is blood flow from the left atrium to right atrium. Same thing is shown in different views. Okay, so this much information is usually enough to diagnose and in most of the times to plan the closure also. Okay, so this is how we plot the ASD and locate the ASD. These are all the margins. Again, important for us to decide which device to put, how to do that. Okay, so these are all the various measurements that we do for these children, various other views. I'm not going to spend too much time on the echo today. In very rare cases, especially in older children, we do something called a transesophageal echocardiogram. It is just like a GI endoscope. We pass the TE probe into the esophagus, okay, and image the heart from behind. So this gives us excellent window to look at the margin size of the ASD. Even during the deployment also, we can see the deployment picture beautifully. We might resort to this at some point of time. So these are the echocardiography pictures, transesophageal echocardiography pictures. Again, this is the hole that we are seeing here. This is the blood flow that is here. Okay. So how does one close a ASD in the cath lab? I'm just sharing a few videos. I'm not going to go to technical aspects of it. Here is a child who is prepped for ASD device closure in the cath lab. It is done like an angiography, but we take a venous puncture. What we need to close is only 1, 2, 3 hardwares. Okay. All these tubes and catheters would go inside the heart and we would do a device closure. You see, this is called as a guide wire. Okay. So this would be inserted into the patient's groin through a small sheath. So this is a 6 French sheath. Okay. 6 French groin sheath. Okay. Once the wire is introduced, so this is what happens. The wire goes inside and I'm inserting the sheath here. Okay. So this sheath would be size of a big ballpoint pen refill, jotter refill. Okay. That would grow into the groin. Okay. So through this, we take the device. Okay, so now this is the sheath introduction process called as a de-airing. Okay, now we have crossed the ASD here. This is atrial septal defect which is crossed. You can't see the ASD in the fluoroscopy. Okay, but once we deploy the device, you know where the defect is. So this is a device closure. I'm deploying a device here. This is one disc in the left atrium, second disc in the right atrium. Now both the discs have opposed the margins and the ASD is closed. Okay, so now you see this is the hole before ASD device closure and this is the device sitting in place. So that is how a ASD device closure is done. Typically, one-time procedure, there is no need to replace the device. Endothelialization will happen in 6 months. We give aspirin for 6 months and stop it. There are extreme rare chances of device erosion or nickel allergy. Maybe 1 in 2,000-3,000 patients, this might happen. Okay, but it's extremely rare. Okay, so surgery is very much possible. As I said, every child can undergo surgery for ASD closure. So this is one of the infants who has undergone ASD closure via sternotomy. So the scars need not be this big always. Okay, there is cosmetic incisions nowadays. Little older children, we can always do cosmetic incisions, subaxillary incision, limited posterior thoracotomy incisions. Okay, these are all cosmetic so that you can't see the scar from the front. Okay, so with this, let's go to ventricular septal defects. VSDs are most common congenital heart disease and they are most misunderstood. On the right hand side, if you see this picture, it's a very sad story of a patient who was born with a birth weight of 2.6 kilos, but waiting for 10 kilos to happen so that the child can undergo VSD closure. This is at 8 months. Baby is only 2.8 kg. Okay. Unfortunately, the child I'm showing here succumbed to a respiratory illness even before we could plan a surgery. So this situation should not be common in present era. So what are the common symptoms of VSD? Again, all are signs of congestive heart failure in infant. Poor weight gain, interrupted feeding, persistent tachypnea, tachycardia, recurrent chest infections, and excessive perspiration. Out of this, poor weight gain, interrupted feeding, persistent tachypnea, tachycardia are the most dangerous. Of course, recurrent chest infections, if you wait for too long, that can happen. But if you close this VSD in infancy, this may not be noticed at all. Excessive perspiration will happen and it is usually persistent in first 1 to 2 years, even after closure, and this is one of the minor symptoms. Okay, so when you have a patient with a VSD, you have to explain to the parents that these are the common symptoms. So there won't be any cyanosis for the patient, there won't be sudden cardiac death with VSD, there won't be any other major disasters for this patient while the patient is waiting for surgery. Okay, so this is a typical chest X-ray in a patient with VSD, huge cardiomegaly and increased pulmonary blood flow. Okay, apart from this, if you examine the patient, the child can have a cardiomegaly with precordial bulge, hyperdynamic apex, intercostal subcostal retractions as the child has a pneumonia. There will be prominent murmurs, ejection systolic murmur and MDM at the apex. Heart sound, second sound is often loud, first sound is normal. Right, so now this is a small quiz-like thing. I know it's an online platform, but you can just do this mental calculation. I have showed 4 X-rays, 1, 2, 3, 4. Okay, all 4 belong to a patient, to patients with ventricular septal defect. Okay, which one is a good X-ray? Which one are you happy to see? So which one will you send for surgery? Okay, that is a question. Okay, 1, 2, 3, and 4. Okay, so just make up your mind in next 1 or 2 seconds. I'm going to go to the next slide. Okay, I'm not expecting an answer. So if you have made up your mind, this is what is a sad story. What is this? All 4 X-rays belong to the same child. Okay. Unfortunately, this child has gone through 1, 2, 3, 4 phases without having undergone the surgery. The 4th X-ray is at the age of 12 years, where the child has already become Eisenmingerized. So this is a famous erstwhile actress, Madhubala. So I think some of the seniors might know her, young generation may not know her. So she was a very famous Bollywood actress of yesteryears. Unfortunately, she come to VSD Eisenmenger syndrome. She could not be operated because she had irreversible pulmonary hypertension, that is Eisenmenger syndrome. Okay, so saying this, let us spend some time on VSD because it's important and it's common. I'm going to take you through mythbusters. Okay, what is a true statement? most of the VSDs close by themselves, majority of VSD close by themselves, few VSDs close by themselves. Okay, what is the most common answers? Okay, this is a trick question again. Okay, so we commonly say 80% VSDs close. Actually, that is not the true statement. Most of the small VSDs that are destined to close do so by 2 years of age. Luckily, majority of the VSDs are small, so they all close by themselves, but some VSDs never close. What are they? Inlet VSDs. They never close. If you have a diagnosis of inlet VSD in the first month of life, start preparing the patient's family for surgery. Subpulmonic VSD or subarterial VSD, whatever size they are, they don't close. Most of them would require surgical closure. Very large VSDs diagnosed at whatever age, they don't usually close. All of them would require surgery. 30 to 40% of moderate VSDs can close spontaneously. This is the only group that we follow up without doing surgery. Otherwise, all 1, 2, 3 groups, we usually advise surgery. Okay. A young infant has come to you. You diagnose a murmur, get an echo done. You get an echo report in your hand with a VSD. Okay. This is a very typical echo report. Of course, this is my own echo report done in 2014 for a 3-month-old baby. So what does it suggest? It says moderate VSD. How does a pediatrician know what is moderate? Okay. So what does it do with this patient? Okay. So what is the location of this VSD? Perimembranous VSD. What is the natural history? Does it close it or not close? That is all questions that you're going to ask as a pediatrician. Let us suppose child is moderate, no symptoms. What are you looking for? What complications do you expect? So this much amount of knowledge should be there with all the pediatricians. Location, we discuss that muscular perimembranous might close, other locations won't close. So let's see what happens if you do not treat this patient. Okay, this is a second patient. This patient, the cardiologist has given a report saying that it's a large VSD and mild pulmonary hypertension. This is not at all possible. Why? Because if you see this VSD picture, there's a large communication between left and right ventricle. Okay, whatever pressures are there in the left ventricle are automatically present in the right ventricle and pulmonary artery. So all large VSDs invariably have severe pulmonary hypertension. Okay, they're all flow related, they're all operable, they're not Eisenmengers. Again, another echo report. Okay, so this person says non-restrictive mid-muscular VSD and Eisenmengerization has already happened. What is the age? See this age, 13-month-old baby. Again, this can never happen. Okay, unfortunately, this is written by a cardiologist. You see the date, 2012. Nowadays, these such reports are less and less common. So more and more people are aware about the physiology nowadays. But you can still occasionally get such reports with you. Okay, so do not believe in echo report says VSD is bidirectional in infancy. All infants are operable invariably. If they are bidirectional, if they have severe pulmonary hypertension, they might be having some other reason which we need to find out and treat. Do not treat these babies with sildenafil. Okay. So what is the size of the VSD? Again, a very, very common myth in echo report. Okay. Different cardiologists will give different echo reports. One says 3 millimeter, one says 4, one says 4.5, 5.5. So what does a pediatrician do? Do not believe the size of the VSD. So this is all a stack of coins. I'm trying to draw a blue line to measure the VSDs. Okay. So this is called as a parallax error. Okay. Parallax error means what? The diameter of the coin was not changed, but the way that we are viewing is different. Okay. So this is a big line and a small line. This is the difference between the size of the VSD. For example, a cardiologist might see the VSD in this way. Second cardiologist might see it in this way. Third might see it in this way. So they will be subject to errors. So do not go by the measurements that is mentioned in the echo report. Okay. So now again, see this VSD. This is a 3D reconstruction of a VSD. See the shape of the VSD. How would you measure this VSD and what dimension should I give? This one, this one, this one. Okay, that's the reason it is not actually correct to measure the VSD. So what is the indication that the VSD is significant? Okay, so if the cardiologist has mentioned large VSD, it is significant. Severe hyperkinetic pulmonary hypertension, significant. Dilated LALV is significant. If the patient has MR, it is significant. If you see aortic valve prolapse or regurgitation, that is significant. If you find any visualization or RV obstruction, it is significant. All of them would require closure, irrespective of whatever else is written in the echocardiogram. What will happen if you do not operate on these children? One, as I told you, extreme failure to thrive and succumb to one of the respiratory infections. Eisenmenger syndrome, if you wait for too long. Aortic regurgitation is a silent killer. Problem is these patients may not come in the first 2 decades. So pediatricians may not be actually aware of this complication at all. By the time they present to us when they are 20, 25, 30, we would be doing a aortic valve replacement for them. A small problem like a VSD, which can be easily tackled with surgery, would end up receiving an aortic valve replacement later on in life. So all of us should be aware that this is a definite complication that can happen. It is important to follow every small VSD for at least first 6 to 8 years of life to detect and prevent this complication from happening. Okay, so this is RVOT obstruction. That means the patient has developed a physiology like tetralogy because of visualization. Okay, there will be growth of musculature here, and the VSD might actually become restrictive, and child might actually become less symptomatic. But this will eventually lead to RV fibrosis. It will eventually lead to tetralogy like presentation in later period of life. Endocarditis, again, all of us know. So VSDs can develop endocarditis. Luckily, the risk of endocarditis is not very, very high. Now, antibiotic prophylaxis also has been stopped for a plain VSD. Okay, so this is one of the natural history that is possible. Okay, so now we have know the natural history of VSD. What is the unnatural history? That means what happens with closure? How good is a surgery? The mortality for a VSD closure surgery, open heart surgery during infancy, is 0 to 4%. This is worldwide. Most of the centers, even in India, have 0% mortality for a VSD closure surgery. So definitely a pediatrician should refer these patients for surgery as soon as a diagnosis of significant VSD is made. Okay, so which VSD needs surgery? Again, the onus should be on the pediatrician, I believe. So you see if the child has clinical symptoms and signs of VSD. If they have, definitely they should go for surgery. Do not believe the echocardiographer. Do not believe your cardiologist. If the child is symptomatic, send them for surgery. It's very simple. So how to perform echocardiography, what information to get? Again, I'm not going through all this. So this is an echocardiography which shows a perimembranous VSD here, where my pointer is. Okay. So treatment options for VSD, if they are symptomatic, straight away send for surgery or device closure irrespective of age. If they are not at all symptomatic and all of them are present, okay, so they'll just require conservative management, no diuretics, no digoxin, only follow-up and nothing else. Okay, so intermediate, very few patients actually. So if they have failure to thrive and recurrent respiratory infections, but none of the things that are in the left-hand side table. So consider pros and cons of surgery, send to the cardiologist, let them also decide what to do. Okay, so this would be the treatment options. Device or surgery, again, device closure is extremely rare. Around 10 to 20% of patients you would do device closure. 80% of the patients are suitable only for surgical closure. Okay, so this is one of the example how a device closure is done. Again, I'm not going to go through all the steps. So this is 1, 2, 3, 4, 5, 6 steps that I have summarized here. So this is the VSD device that is sitting in position. Okay, so here a large device is, large VSD is closed with a device. It is possible, but again with definite indications. Okay, so last part I'm going to come to patent ductus arteriosus, which is a very, very common thing for a neonatologist. Okay, and definitely for pediatricians as well. So this is textbook classification, Krochenko's classification, but there's another new addition to this, which is type F duct, which is fetal type of duct, which has been described in last 5 to 6 years. Okay, so in a preterm baby, this is what is the shape of the PDA. So this is all in the pediatric age group. Okay, so most common age of presentation, neonate can present with respiratory distress, ventilator dependency, or oxygen dependency. Infants present similar to VSD. Older children, they just present with murmurs, okay, because their PDAs are small. Okay, so this is the chest X-ray, again, cardiomegaly, increased pulmonary blood flow. So these are the different babies who have undergone VSD, PDA device closures in our institutions. You see, look at the grams of these babies. So all these patients are symptomatic. Many of them are on ventilators. All of them we have done preterm PDA device closures. Some centers in India are doing it routinely. We have an experience of doing more than 25 such babies in our center. So again, excellent result. It's a boon for this baby because it would actually shorten the duration of the NICU stay, but it is definitely possible. Okay, so this is how a PDA device looks after the closure. Okay, which baby needs closure? Any hemodynamically significant PDA should undergo closure. Okay, if they are not significant, that means if they don't have any symptoms, but if they still have continuous murmur, they still require closure. Okay, that means asymptomatic continuous murmur PDA would require closure. All symptomatic babies will require closure. Okay, so if they don't have any murmur, no LLV dilatation, do nothing. Just presence of a tiny PDA will not harm the baby in any way. Okay, so what do you do? Device or surgical closure? Again, this is one area where interventional cardiology and device closures were taken over surgery. Okay, majority of these patients do undergo device closures now. Beautiful devices are available and delivery systems are available. Preterm PDA device closure more than 700 grams is possible. How do we assess echo anatomy? Again, I'm not going through the echo, but just see, this is actually the 3D reconstruction of a PDA. So this is the echocardiogram. Okay, so such beautiful demonstration of PDA is possible just by mere echocardiography. We get all the parameters on the echo, like size, hemodynamic significance, selection of device just by an echo. Okay, that's a PDA. Okay, so these are all the PDA echocardiograms. Okay, so this is how the device closure is done. Okay, we put a device in between the aorta and the pulmonary artery. So I'm not going to show how a PDA device closure is done. Okay, but I'm going to skip to the conclusion part of my presentation, which is severe aortic stenosis and severe pulmonary stenosis. PSAS, most of them are asymptomatic. That means, so these patients are referred only because of murmur. Okay, so how do you treat them? Okay, so usually balloon dilatation is possible. So this is one of the baby who has severe aortic stenosis but misdiagnosed as LV dysfunction. Okay, what are we doing? We are doing a balloon aortic valvotomy. Okay, so this is a balloon aortic valvotomy procedure. This is a aortic valve which is blocked. Okay, so see the difference in the echocardiography. This is before and this is few minutes after the balloon dilatation. Your cardiomyopathy is gone. LV function has become normal. Okay. So similarly, this is an example of a aorta. Again, similar presentation, coarctation of aorta. Immediate improvement on table. LV function has improved. Okay. So what do we do? Even if they are asymptomatic, go by the gradients. More than 65 in pulmonary stenosis, indication for balloon dilatation. Aortic stenosis, more than 65. Coarctation, if they have upper limb hypertension or more than 20 millimeters gradient, you take them up for balloon dilatation or surgical correction. So with this, we have come to the conclusion of acyanotic congenital heart diseases. So now, if it is required, we'll take questions now, or we'll finish the second part and then go for questions. I'm going to stop share here.
Uh, yeah, sir. Thank you. Thank you very much for your detailed and more illustrative presentation, sir. So we have a few questions. So let us take it at the end of the session, sir, with both the speakers completed. Yeah.
That's
So
good,
now,
sir.
yeah. Now call upon Dr. Sonia for your presentation. You can share your slides. Yeah.
Yes. Is it visible, sir?
Yeah, it's visible, ma'am.
Yeah, visible.
So a very good evening to everyone and thank you so much for this opportunity. I am Dr. Sonia Karapurkar. I am a pediatric and fetal cardiologist as described earlier. So I will be speaking about prenatal diagnosis of congenital heart defects and its impact on treatment outcomes. The highlights of my today's talk include necessity of fetal cardiology as a subspecialty, how a prenatal echo or a prenatal diagnosis has been a paradigm shift in CHD care, how to obtain the necessary information on a fetal echo, a basic fetal echo protocol, and where does the Indian scenario stand currently with respect to prenatal diagnosis. So, as cardiologists, what is a goal of an echo? We started doing an echo first for an adult, then for a child, then for a newborn. Now we have evolved and started doing echoes even for a fetus. However, how is a fetal echo different from the other three? So when we are doing an echo for an adult or for a child, our aim is to either do a detailed anatomical assessment in CHDs to aid surgical correction, or we are trying to assess the function or the pulmonary pressures, or we are evaluating for a valvular heart disease. However, when it comes to a fetus, this fetus is someone who is yet to be born, and thus our goal is completely different. Here, we are trying to see either whether does this baby have a correctable lesion. In case of a correctable lesion, we can always plan the delivery in a tertiary cardiac care center where we are able to expedite the cardiac care. Or does this baby have a very complex condition? So despite multiple surgeries, it's only going to amount to a palliative care. At such a time, we give this information to a parent. It is up to them whether or not they want to continue this pregnancy or whether do they want to do an extensive evaluation, genetic evaluation for their future pregnancy purposes. Sometimes some conditions are amenable to in utero therapy. Conditions like arrhythmias most commonly show excellent response to in utero therapy, or conditions like fetal cardiac tumors respond very well. And this is the subset which benefits maximum with a fetal diagnosis. We are able to prevent a fetal demise. Last but not the least, there are certain variants which are very benign, like an echogenic focus or a bilateral SVC. At such times, ruling out any significant heart defect and allaying a parental anxiety throughout the period of gestation becomes very important, because this leads to an unnecessary anxiety in the expecting couple. So, at present, what is the congenital heart? What is the problem statement at a global level when it comes to CHDs? Globally, CHDs are the most common congenital malformations encountered, with a birth prevalence of about 6 to 8 per 1,000 live births. Of these, almost about 25% are critical CHD. So critical CHD means what? A CHD which requires a definitive procedure or any procedure within first year of life. So they contribute highly to infant mortality. And they are more important in countries where the infant mortality rate is already on the lower side, because of course, developing countries have other important causes of infant mortality rate as well. Typically, how are CHDs diagnosed, or what is the timeline for CHD care? Wherever that a child has been following up after birth or immediately after birth at the time of discharge, first the clinician who encounters such a baby has a clinical suspicion, probably based on certain symptoms. There's poor weight gain, failure to thrive, or repeated respiratory infections. Based on this, a clinical suspicion is made. Further, they make a provisional diagnosis of a CHD, and then this patient is referred and transported to an actual cardiac center where the treatment is going to happen. After this, the baby is optimized with adequate preoperative care, and then the baby undergoes a definitive procedure which treats this baby. Now, from the time of clinical suspicion till the baby reaches the cardiac center, this is where maximum mortality sets in or morbidity sets in. The pulmonary pressures may rise, the baby may become inoperable, sepsis sets in. Sepsis is an extremely morbid condition. Sometimes, even during transport, mortality can happen. Now, to this picture, if we add a prenatal diagnosis, then with a prenatal diagnosis, we are able to actually plan the delivery in a cardiac center and circumvent all these steps and instead get a lead time. The baby will be in a more optimized condition and will give better surgical outcomes as well. So this is how a prenatal diagnosis has been a paradigm shift in care of critical CHDs. First, the family will be aware, they'll be expecting what is coming next, they'll be prepared and motivated. Neonatal transport will be avoided because it's the most delicate time. Cardiac care will, of course, be expedited. It ensures a better preoperative state without increased pulmonary pressures or sepsis. Thus, of course, a shorter pre-op ICU stays, less cost utilization, better post-operative outcomes, and more importantly, improved long-term neurodevelopmental outcomes. These are just different papers reiterating the same. Now, when we do a fetal echo, what are the objectives? What is the information that we're trying to obtain? First, we're trying to get maximum anatomical information, including situs, cardiac axis, and the segmental anatomy. Then we are trying to do a detailed functional assessment. Third, last but not the least, rhythm assessment. Different things we use for functional assessment include myocardial performance index or ejection fraction. Rhythm assessment is done with a Doppler or with an M mode. And of course, the extracardiac important structures like systemic veins, ductus venosus, area behind the heart, etc. I'll be speaking about each of these as we go ahead. So now, what is the approach? For whom do we do a fetal echo? Do we do it for everyone or for selected cases? One is to do a target screening for high-risk pregnancies. Other approach is to screen every pregnancy. So we generally advise to screen only the targeted high-risk pregnancies. Now, how do we know which pregnancy is a high-risk pregnancy? Let us see these indications one by one. First, let us look at fetal indications. Any fetus who has shown an abnormal 4-chamber view in an anomaly scan, or is known to have certain extracardiac anomalies like spina bifida, etc., or known chromosomal anomalies, non-immune hydrops, very important to look at cardiac function, or other things like increased nuchal thickness, etc. Maternal indications like if the mother herself has a CHD, autoimmune conditions in mother like SLE or Sjogren's, any teratogenic exposure or metabolic infections, intrauterine infections like the TORCH group. Then familial indications like a previous sibling with a CHD or existence of Mendelian syndromes in the family. Now, what is the ideal time to do a fetal echo? As we know, there are 3 trimesters, of which the second trimester is an ideal time because the structures are well developed. And before 24 weeks, if we have a diagnosis at hand, then the parents are in a good position to take a decision. So, what protocol do we use or how do we go about a fetal echo? ISO guidelines are the most commonly used guidelines. It's an International Society of Ultrasound in Obstetrics and Gynecology. So these are practical guidelines based on which we do our fetal echoes, which covers and helps us to get maximum data. This is nothing but a systematic or a segmental approach. What we do is nothing but cut it in these different planes. As you can see, the first plane will give you information on the situs, the atria, ventricles, and these are the different views that I'll be describing, the outflow tracts, the 3-vessel trachea view, etc. Schematically, this is all that this is helping us to see. Like we do a segmental assessment in a postnatal echo, similarly, we're looking at the atria, ventricles, the great arteries, the AV junction, the VA junction, and the systemic and pulmonary veins that are draining into the atria. Schematically, if this is how a heart is seen, when you move your ultrasound probe across, because this time we are screening across the mother's abdomen, different layers of the mother's abdomen, the uterus, the covering fetal sac, the amniotic fluid, then the fetus's body, and then the fetal heart. So these are the different planes that you cut. The first plane that you cut will show a apical 4-chamber view. The only thing that we need to do after this plane is keep on sweeping cephalad. Keep on sweeping towards the baby's head. The second ray will pass into the LV-OT view and show us the left ventricular outflow tract. The third plane will give you the 3-vessel view where 3 vessels are seen. I'll be speaking about each of these. Then, of course, a 3-vessel trachea view completes the scan, and then we have a few sagittal views. Now, first and foremost, we'll just quickly see what information these views give us. As of the abdominal situs, it's important to determine the situs because situs abnormalities are strongly associated with heart defects. Whenever the baby is in a normal position with the head down or a cephalic lie, at that time, the spine, stomach, and the portal vein often are in a clockwise direction. And this is called as situs solitus. In a cephalic position, when spine, stomach, and vein are in clockwise orientation, this is called as situs solitus. You appreciate all the other structures as well. This is the spine, descending thoracic aorta. This is a vein. This is the liver shadow, and this is the stomach bubble. Then going ahead, the 4-chamber view, which was the first sweep. This is how a typical 4-chamber view appears in the AC plane of a fetus. Going with the schematic diagram, this is all the information that we're able to see. We can see the 2 atria, we can see the 2 ventricles, both the AV valves. This is the spine, the descending thoracic aorta, exactly as is seen here. You can appreciate the pulmonary veins as well, like they're seen here in this diagram. You can appreciate the moderator band. This completes the checklist of a 4-chamber view. Same view you can appreciate here as well. The crux of the heart, the AV valves, which are intact with a normal offsetting, the moderator band, descending thoracic aorta, pulmonary vein. So this completes the checklist: chamber symmetry, nature of the PFO, pulmonary veins, crux, moderator band, etc. Heart is occupying 1/3 of the entire chest circumference. Area behind the heart, which is this, which shows the descending thoracic aorta and the IVC as well, and the distance from the spine. With this, a complete assessment of a apical 4-chamber view has been done. Apical 4-chamber view is a view which is most commonly obtained on anomaly scans, and most of the major CHDs which are not correctable will show an abnormal 4-chamber view. If a 4-chamber view is normal, then broadly, even if you have missed a congenital heart defect, largely it is likely to be correctable. It's a dictum that is used, not hard and fast, but a guiding principle. Of course, we record a movie with the color and show that the inflows are patent. Now going ahead, the next sweep, the Kepler sweep, will open the LVOT. So from the apical four-chamber view, just a clockwise rotation will open the LV outflow tract and show us the aorta. The two things that we see here is the aortic outflow, whether it is patent. Secondly, a septo-aortic continuity, which rules out a perimembranous VSD. This is a RVOT view, which is obtained on a anti-clockwise rotation. Like from a apical four-chamber view, a clockwise rotation will show LVOT, anti-clockwise will show an RVOT, and it will show the branch PA confluence, which is most important part of this particular view. Now, as you can see, a clockwise rotation gives LVOT, anti-clockwise rotation gives an RVOT, which means both the outflows are crossed. And normally, in a normal heart, outflows are always crossed. That is why it is important to show the outflow crossing. Here, if you can appreciate, as you can see, the aorta is going towards the shoulder, whereas, aorta is going in one direction, whereas the PA is going in another direction towards the spine, as is expected postnatally. So this is a still image of both the outflows crossing each other. Then further you show the three vessel view, the further Kepler sweep. So three vessel view will show three vessels, the pulmonary artery, the aorta and SVC, as you can see here. Now the dictum for this view, to know that this view is normal, there are three things. Always remember left to right, anterior to posterior, and in descending order of the size. It will always be PA, aorta and SVC. PAS, left to right, antero-posterior, greater to smaller in size. Because in a fetus, the right side is always dominant. That is why the pulmonary artery is larger in size as compared to aorta. Now going even further, this is a three-vessel trachea view. Three-vessel trachea view is in fact showing two arches. One is the aortic arch, and in a fetus, the ductus is still open. So the second arch that you see is a ductal arch, and they join each other always to the left side of trachea whenever your arch is left-sided. So this view is important to determine both the arches, to show the flow in both the arches, because the flow in both the arches in a normal fetus will always be in the same direction. We will not have a flow reversal in either of the arches. Whereas in duct-dependent circulations, you will find flow reversal in the respective arch. Second importance of this particular view is to determine the arch-sidedness. Because a 3VT view will always be the V that is getting formed. Why it is called 3VT is it's forming a view, forming a V. This V will be to the left of the spine in a child with left aortic arch. If it is to the right, it means the arch is right-sided. And right-sided arch, of course, needs further evaluation for 22q deletion, etc. Now, these are two sagittal views that are taken. Three sagittal views, in fact. One will show the ductal arch, which is this. So ductal arch is nothing but it is showing the continuity of the ductus arteriosus. Now ductus arteriosus is nothing but a branch of pulmonary artery. It will continue along with the RV from the pulmonary artery and go on to join the descending thoracic aorta. So it has a more anterior lie as compared to your aortic arch. This is how a ductal arch is seen. Then going on, this is how a aortic arch is seen. It will come from the LV and it will show the head and neck vessels. This is how aortic arch is seen. So the sagittal view showing the ductal arch, aortic arch, and the SVC, IVC, as you can see here. Here also you can appreciate this whole thing is the IVC, which will always be parallel to the descending thoracic aorta, and here above is the SVC. Now, further advanced from this is the 3D, 4D imaging, which is a novel technique, has a lot of implications in today's era of advanced fetal imaging. In a stick imaging or a 3D imaging, a lot of information can be obtained within a small time frame. However, it is skill-based and machine-based, and it has a lot of implications in more specific things like planning the postnatal surgical planning, etc. These are some different stick rendered images that I'm showing to show how beautiful these images can be seen and how much information they can give. Now, going ahead, what are the benefits of prenatal diagnosis? As we've seen, you get a complete cardiac diagnosis before the baby is born. You rule out extra cardiac anomalies. If you have a cardiac anomaly, of course, you will do a detailed scan to rule out other systems association. Family will be better prepared. They'll have time to get everything ready. Different treatment options and the prognosis of the baby will be discussed with the parents beforehand. There's more parental preparedness. From the management perspective, how do we group these conditions or how do we approach them? First group is that of treatable anomalies. In treatable anomalies, most commonly that we see in fetal diagnosis include a tetralogy of fallow, transposed great arteries, or DORV, coarctation, TAPVC, etc. These are broadly completely correctable lesions. So these fetuses will benefit with a planned delivery in a tertiary cardiac care center where the cardiac care can be expedited. And with one definitive surgery, the child will have a normal life after that. Certain complex anomalies like single ventricles, isomerisms, or hypoplastic left heart, no matter how many surgeries we do, it's going to amount to a palliative correction. These expectant parents can consider whether they wish to continue this pregnancy. Even if they wish to continue a pregnancy, how much do they wish to opt for a complete cardiac care or do they wish to opt for a comfort care? Of course, at this time, they can consider a genetic workup for a prospective antenatal counseling and planning for the future pregnancies. In utero therapy becomes important, especially for arrhythmias. Certain times for a critical aortic or pulmonary stenosis, they will benefit with a fetal BAV or a fetal BPV. And of course, cardiac tumors, which will benefit with transplacental treatment. Also, autoimmune heart blocks mediated by anti-Rho, anti-La, they show excellent response to steroids in first and second stage. Certain anatomical variations, like we discussed, of fetal echogenic focus or a bilateral SVC, only role is to allay the parental anxiety. Lot of work has been done in this, and these are different fetal papers which are showing how a prenatal diagnosis has changed the postnatal care, has had good impacts, and has improved and optimized postnatal outcomes. To conclude, most important role of a prenatal diagnosis or a fetal diagnosis is to optimize the resource utilization, reduction in long-term morbidity, reduction in the total healthcare cost, and of course, new frontiers for research. Role of fetal interventions as well. Thank you.
Thank you, Dr. Sonia. That was excellent. And what time do you actually expect some? So, for example, a target scan or an anomaly scan is done by an sonologist and shows some cardiac anomaly has been fixed. So, what time do you ask for a fetal echocardiogram to be fixed by the pediatrician or somebody else?
Sir, ideal time would be between 18 to 22 weeks. Because by 18 weeks, both inflows and especially the outflows are well developed. So the assessment is complete at that time.
Okay.
Plus, there is enough time for us to do a genetic evaluation or any other extra cardiac evaluation and get our results by 22, 23 weeks, which still gives the parents some time to take a decision further.
Okay, fine. And we have a question in the chat box to Dr. Srinivas. What's the role of enalapril in large VSD, sir?
Okay, so when it comes to medical management of any left directions, VSD, PD, AP window, so the topmost priority, descending order of priority will be diuretics. Diuretics remains the mainstay of therapy. Maximum symptomatic benefit is usually got by diuretic use alone. So as an add-on drug, digoxin might be sometime helpful, especially when you notice that there is persistent tachycardia in these patients. So as a third line drug, yes, enalapril can be used. Enalapril usually decreases the systemic vascular resistance. So theoretically, it should decrease the amount of left to right shunt happening, but the benefits are not that profound. Okay, so yes, it can be given, so but of a limited benefit, but it should not get a priority over the diuretics. Diuretics are probably first 1, 2, 3 lines of medications. Digoxin next and enalapril the last.
The other question in the to Dr. Srinivas is sorry. Which echo parameters are best for deciding hemodynamic significance of a PDA?
Okay. So PDA, there are a few important hemodynamic significance determinants. One is the impact of left to right shunts on the neonatal heart. Okay, if there is a left atrial and left ventricular dilatation, so it is one of the significant parameters. Okay, there is left atrium and aorta ratio. Okay, so anything more than 1.5 LA to aorta ratio, it is significant. So third will be Doppler parameters. Whenever you have this systemic steal phenomenon, for example, reversal of Doppler from the abdominal aorta, that is the flow reversal in the GI vessels like celiac trunk and supramesenteric artery. So they are one indicators. And of course, there are many clinical parameters. So clinical matter parameters is if the baby is able to extubate the baby, if the baby is oxygen dependent, baby has raising lactate, baby has early signs of NEC. So baby has early signs of even renal failure. Baby has early signs of hepatitis or hepatic failure because of ischemic hepatitis. All of them are parameters. Usually it's a combination of more than one or two factors. And of course, the initial set of management would be conservative management with fluid restriction, ventilation, optimization of feeds. Next comes the medical therapy like giving ibuprofen or paracetamol. So if both of them fail, then only they would go for either surgery or device closure.
Thank you. You have
sorry, Dr. Srinivas, sorry, just
Yes,
on a
sir.
continuation of that particular case question. Would you consider the flow patterns for deciding the hemodynamical significance of a PDA?
Yeah. So if you talk about flow patterns, actually we are discussing about two different physiologies here. Okay. So one, there is a PDA and a pulmonary hypertension. So these PDAs will have typically right to left or bidirectional flow. Okay. So one should not attempt to close a PDA when the PDA is bidirectional shunt. Bidirectional means at some part of cardiac cycle, the lung pressures are higher than the systemic pressures. If you subject these patients for closure, they would not do well. Okay. So then only indication for closure is it has to be completely a left to right shunt. Okay. In a neonate, if you see the flow gradient between the aorta and the pulmonary artery, you can also calculate the PA pressures. Typically, a large PDS will have low flow gradient. Okay. A restrictive PDA will have a higher flow gradient. So this is not the pattern in a neonate. Neonate usually will have a low flow gradient. It will be exclusively left to right shunt. And all the parameters that I said will happen only if the PDA is exclusively left to right. If the patient has bidirectional or right to left, you have RARV dilatation because that is indicative of pulmonary hypertension. LALV dilatation will not be there. So left to right shunt means all left side structures are dilated and flow is exclusively left to right shunt. In a bigger child, yes, you will have a continuous murmur. You will have a gradient. Okay, so here also, if you have volume overload and symptomatic, you close it, otherwise don't close it.
yeah. So to again to Dr. Srinivas. So this is something like a question on what would you like to know what sort of baseline evaluation you would advise for teenagers who take active or competitive sports on a regular basis? Because we see nowadays a lot of teenagers taking up sports, and we see also hear about teenagers having some major cardiac events like that. Yeah.
Right, sir. Sir, there are guidelines, but not Indian guidelines. US has guidelines about sports fitness certification for children who would want to participate in competitive sports. Okay, so most of them a good clinical examination, a thorough history taking, especially history of evaluation of palpitations, arrhythmia, syncope, family history of sudden cardiac deaths. All these things should actually stratify the risk factors. If any of the risk factors or red flag signs are identified on history and general physical examination, so these children would have to undergo for a cardiac evaluation. When they come to us for a cardiac evaluation, so if the patient is already referred to me, naturally we would rule out common cardiac conditions like presence of any arrhythmia substrates by doing an electrocardiography. And we'll also do an echo to see if the patient has an asymptomatic underlying hypertrophic cardiomyopathy. So these are the two things that we do. So in generally, most of the children, this much is enough. If there are any abnormalities in evaluation during history, physical examination, ECG, echo test, or any family history, then we would evaluate them particularly for further risk factors. Otherwise, most of the times, a good general physical examination, at most an ECG should be enough to allow them to participate in competitive sports.
Question to Dr. Sonia. When we find an echogenic foci, what's the significance? So I know. This is again to Dr. Srinivas. When we find an echogenic foci, what's the significance? Less than 5 ASD, asymptomatic, can we wait? These two.
Yes, sir. Echogenic focus is partly Sonia also, but I would answer that.
So that, yeah.
Echogenic focus is the most common finding of an insignificant finding in a fetal echo. So many people joke that this echogenic focus on a anomaly scan pays for EMI for the echo machines. Okay, so that means they are insignificant. Only we just need to reassure. Very rarely, echogenic foci are associated with aneuploidies. So most likely Down syndrome and all. But if a good double, triples marker tests have already been done, if the risk factor for Down syndrome is very low, usually we do reassure them. So otherwise, they are not of much significance. So coming to 5 ASD asymptomatic, definitely we should not be doing anything for these children, especially if there is no right atrial and right ventricular enlargement. So usually we need not treat these children.
Okay. Question to Dr. Sonia. How likely that TAPVC is missed in a fetal echo?
So very likely to miss actually, because pulmonary veins are not very easy to image. They are seen on a slightly posterior sweep. And even with good imaging, we may be able to show only a few pulmonary veins. The common sign that you see in a TAPVC is that the left atrium will look bald and you won't see anything draining, and you may see a structure in the area behind the heart, which is actually the confluence of the pulmonary veins. The confluence behind the LA of the TAPVC. However, very likely to be missed. We in fact give a disclaimer in our fetal echo reports that pulmonary venous anomalies cannot be ruled out conclusively on a fetal echo.
So even in best of centers, chance of picking up TAPVC is about 50%.
A question from my side. So, first child with the cardiac anomalies, how even the anomaly scan is normal by a sonology center. Do you advise a fetal echo for all these children with the first child who has a cardiac problem?
It will be better, sir, because usually anomalies, it depends on how the heart has been evaluated in the anomaly scan. Commonly, a 4-chamber view and a 3-vessel view together picks up about 70% of CHDs. However, when you do a detailed sweep, including all the other views, 90 to 95% CHDs can be picked up. Since with a previous sibling who has a CHD, the chances of the next sibling having actually doubles than the general population, it may be advisable in these patients to get a detailed fetal echo done.
So the problem is, even if the first child has a small VSD or anything, the second child might have a complex disease also is likely. So it is a definite indication that you need to do a fetal echo if one of the immediate blood related siblings are having a CHD.
Okay, great. I think this is the last question from Dr. M.S. Vishwanathan. What sort of echo findings of IVC or the right atrium is relevant in chronic liver disease?
Right. Very big question, actually. The liver can be affected because of the right heart dysfunction. Okay. And in a chronic liver disease, there can be an impact on the cardiac function as well. Okay. So in the first subset, when we are saying that there can be liver dysfunction, there is something called as congestive hepatitis. Let us suppose some patient has a carpulmonale. So it is a chronic right heart failure symptoms, which actually leads to back pressure changes, and yes, even cirrhotic liver is possible. Okay, this is one subset. So that means a liver is like a check dam behind the gates. Okay, the first pressure changes that happens because of the right heart usually happens on the liver. All of them will be seen. So what we call as tender hepatomegaly is also a sign of that. So this chronic congestion actually can lead to liver dysfunction. So that is the cause and effect. Cause is cardiac, here liver is the effect. So second is, let us suppose patient has an alcoholic cirrhosis in a long term. Okay. So these patients also can have something called as high cardiac output failure. Okay. So these patients will have a high cardiac output cardiomyopathy. So this is a different form of interaction. So liver and heart are closely associated. Even in patients who have to actually undergo liver transplant, cardiac evaluation is a must. Okay, so these are the interaction between the liver and the heart.
Okay. One more question has been received. Okay, yeah, it's all significance of fetal cardiac calcifications and how to evaluate it to Dr. Sonia.
Often these calcifications only are the things that are seen as an echogenic focus. More commonly, they are seen on the papillary muscles or on the chordae. As Sir has said earlier, they are nothing but they are soft markers of aneuploidies. And if other markers of aneuploidies are not present, then they don't need evaluation further. However, if the calcification is more massive or in areas where we don't expect it or pericardial calcifications, then evaluation for certain intrauterine infections becomes important. And if calcifications are present in other organs as well, like the brain or the kidneys, then ruling out tuberous sclerosis or other genetic syndromes becomes important.
And one more question to you. How about hypoplastic left heart syndrome diagnosis by fetal echo?
So, frank hypoplastic left heart will set in very much earlier in gestation. Why this is slightly tricky is that in a fetus, always the right side is more dominant. So, left side will always be small. Especially in later gestations, right side starts to become bigger and bigger. But frank hypoplastic left hearts will show this this disproportion right from the beginning, and diligent monitoring is required because sometimes it may start as just a small aortic stenosis or mitral stenosis. The inflow will be smaller, and eventually, because of poor flow into the left sided structures, it can evolve into HLHS. So whenever there is a doubt, a close follow up, every 2 weekly follow up becomes warranted until we've ruled out a hypoplastic left heart. Showing a patent left-sided inflow, a patent left-sided outflow is most important to rule this out.
So the last question from me. So usually, so in a pediatric, general pediatric OPD, the two symptoms or one sign and one symptom which we usually refer to a pediatric cardiologist is one is a left-sided pain, the other is the or innocent murmur picked up in a child. So, what are any other basic investigations we can do before referring to a pediatric cardiologist? Or that's the first question. The second question: any other symptoms should we ask, like sign should we look for, which is pertaining to this can be an organic heart disease or something like?
Sir, as I said, the 5 parameters that you look at is history, physical examination, and in physical examination, intensity of murmur, abnormalities of the heart sounds, saturation, and blood pressure. So this actually is these 5 parameters were in NADA's criteria originally. Okay, so if you have 2 major and 1 minor, or 1 major and 3 minor, it is diagnostic of a heart disease. So this is about a murmur and evaluation. Okay, so it is very common to have functional murmurs in young children, especially when they are come to pediatrician with fever or any other hyperdynamic circulation. Okay, most of the times we end up doing an echo just for reassurance, because every time they go to pediatrician, they keep on saying murmur and parents are always worried. It's mostly to alleviate the anxiety of the parents. When it comes to chest pain, yeah, chest pain is a very important symptom, especially the TV news and the incidences that has been reported in various cities, child dropping dead and all those things. It is very scary for the parents. So here, the medicine people and adult cardiology people, they have extensively studied about the myocardial infarction. They know what is cardiac chest pain, what is non-cardiac chest pain. So here for pediatricians, we have to take history in similar fashion. What does it mean? A cardiac chest pain means it should happen only with exertion. Okay, so it should be central chest pain. It should be like a pressure applied on the chest, not like pricking and going away pain. Third is it should get relieved with rest. Okay, so if all 3 parameters are there, they are suggestive of cardiac chest pain. So that means any chest pain a child has on exertion, there should be a high alert. A chest pain that happens paradoxically, that means the child is watching TV, suddenly says chest pain goes away. Usually it is not significant. Okay, and if there is a history of premature coronary heart disease in either of the parents or the grandparents, and if the child is an adolescent, it's always better to get them evaluated. Okay, so standard evaluation would be just to look for the risk factors for a coronary artery disease in an adolescent age group. That is, you send routine blood tests, including cholesterol, get an ECG done, and then you can send for a cardiologist. Other common symptoms are for you in office-based practice is syncope. Okay, so syncope and chest pain are the two things which have common red flags.
Yeah.
Okay,
Yeah.
symptoms
Well
happening with exertion, always it is a red flag. Okay, so do not ignore that. Immediately send them for evaluation.
good, sir. Very well done. So if anyone has to ask a questions in that, you can unmute and ask. If not, Thiru, sir.
Oh, fine.
Yeah.
I think most of the questions anyway came out from me, but thank you very much, Dr. Srinivas and Dr. Sonia. It was really very nice sessions. I think Dr. Srinivas simplified the whole cardiac physiology actually in a very, I think probably most pediatricians may not understand people, except for those who handle cardiac kids a bit more, but it was very wonderful. Thank you very much, sir, for making it very simple. And your interventional videos were very nice actually. So it was nice to see those which we don't get to see that often. So thank you. And Dr. Sonia, of course, your fetal echo session was very nice. Thank you very much.
Sir, I'm Dr. Priya. I'm a pediatrician. So how often do we do the echo screening? Some people say it's once in 6 months. Some people say just even follow up once in a year. So because parental anxiety again. So how often do we do the screening if it is diagnosed with a ASD or a VSD?
Okay, madam. So
Though we
if it is an ASD, madam, there is no need for so frequent echoes. Let's suppose I diagnose a significant ASD in infancy. What I would say is you go back to your pediatrician, just monitor weight gain and symptoms. That is enough. Once in a year echo should be enough because nothing will change in a year for the ASD, at least for first 3 years. So the first time I would want to see the child again is around 3 years if the patient is being followed up properly from a pediatrician. If any symptoms, they'll come back earlier. Otherwise, they won't come back to me till they are 3 years. In a child with a small VSD, we are talking about a restrictive VSD, which is otherwise asymptomatic child. First 6 years, we would do an echo once in 6 months. So this is to look for any possibility of aortic valve prolapse and aortic valve regurgitation that is developing. Usually this is asymptomatic. It can't be picked up by auscultation. Okay, after the age of 6 years, once in a year should be more than enough. So apart from these two things, clinical follow-up is always important. So every time they come to a pediatrician for vaccination or a very healthy baby clinic, we would check their weight gain and symptoms and development and things like that. So that should be more than enough.
Thank you, sir.
So, sir, can we conclude the meeting, Thiru, sir?
Yeah, we can. I think.
Yeah.
So,
So first of all, thank you, both the speakers from the pediatric cardiology segment, Dr. Srinivas and Dr. Sonia, for your extensive presentation and your clarification of all the queries in an elaborative way. So thank you for your time and thank you for your presentations. And thank you, team IAP TNSC. And all the viewers who have joined on this platform on the Sunday evening. So with this, we end the session. Thank you.
Thank you, sir.
good night.
Thank you.
Thank you.